Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. It is the 204th episode of the CodeCast, and today I'm actually recording from my new office inland in Riverside, California. My remodel is done in my house, and I had to move my office closer to my house, so I am definitely away from the beach, which kind of makes me sad, but I have a really big picture window, and so it's good today, but it is warm. It is 91 today, so it's definitely warm. In saying that, I have a little bit of different setup, so hopefully you don't hear my ceiling fan in the background and just keeping things cool in the office. So today for the CodeCast, I'm going to be sharing some insights on healthcare industry updates. I do this every once in a while when there's some breaking news. But there's some things that you may not be aware of that aren't exactly breaking news, but if you aren't active in searching for the information, or if you're not on LinkedIn, where it seems like LinkedIn is 80% medical, or if you just don't have the time to read all of the news pieces that are sent to me or brought to my attention or to your attention, this would be definitely the podcast for you today. So this will be a mixed bag of information, and hopefully you'll find it helpful where you don't have to go search it out and figure out exactly what's going on, but information you'll need as a healthcare professional to do your job and to make sure your billing, coding, and compliance office is well protected. So something came out recently, and I just thought it was interesting because it's a significant change that's worth noting on ABNs, which are Advanced Beneficiary Notices, and I feel like it was kind of done in secret, but Centers for Medicare and Medicaid Services, so CMS, despite the ongoing COVID pandemic, they continue to update regulations and manuals in order to ensure that correct regulatory information is available to everyone. So 2 weeks ago, they released 26 pages of changes to the manual instructions for how to use an ABN notice, and that is, again, the Advanced Beneficiary Notice of Non-Coverage. So this update comes after CMS made its usual every 3 years updates to the ABN form and completion instructions, which we all get it, we glance at it, and we just don't look for anything more than cosmetic adjustments, to wording, and is there going to be any, consequence or anything. But here are some things that were updated that I thought were important to note. So the revision they added the word healthcare before every instance of provider. This seems to be done to separate healthcare providers from suppliers. So that's an important change. As most of us know, ABNs are not always needed, and there are situations in which an ABN is not required. So for instance, for cosmetic surgery or custodial care, in the new manual instructions, they changed the word voluntary to optional to describe these situations. So now ABNs are either mandatory or optional and no longer mandatory or voluntary. Now, this is why this makes a difference, and be really clear on this. In describing its optional use of ABNs, CMS added the phrase, quote, CMS strongly encourages healthcare providers and suppliers to issue the ABN for care that is never covered, unquote. Okay, so why would they do that? We've never had to do that for not covered before. And what regulatory weight does strongly encourage carry? That's actually a legal question, but an administrative law judge, if you have to take it to that level on an appeal, may not look as kindly on a healthcare provider that did not issue an optional ABN when CMS strongly encouraged, get it, them to do so if a patient filed an appeal and claimed they were not aware they would be held financially liable for a service. So that was kind of big to me. There is one significant change worth noting which will require adjustment to the actual use of the ABN. If you are presenting an ABN to a patient with Medicare or Medicaid, you can only charge the patient after submitting the claim to both payers, so if they're Medi-Medi, and getting twin or dual denials. As a result, on the ABN, you must cross off the corresponding sections in option 1 for these patients. If you have a dually eligible patient, be sure to read the updated manual or form instructions on that. They also reformatted the sections on ambulance, hospice, rehab, and home care. So most notably, they removed the case examples that were in the previous version, and they also removed any reference to the use of the abbreviations that was present in the home health section of the previous manual. So I'm not sure why they were removed because it wasn't clear, and I know that they were very helpful, but their example of unclear abbreviations was pretty straightforward, where they explained that PT used by home health could be physical therapy, pro-time, or part-time, and abbreviations on forms should always be avoided. Expecting a patient to know a medical abbreviation and understand how it applies to a situation has all kinds of risk over it. And then finally, everyone welcomes the removal of obsolete sections of manuals. And in this case, CMS removed the 4 pages that pertain to the use of an ABN when the patient hit physical therapy cap, since there's no longer caps on that. So it's just when it's medically indicated. So just make sure you look at that, and you can find it in the change request 12242, and you can find it online. So make sure you go to cms.gov, and again, you're looking for change request 12242, and it's also on our regulation, R10862CP. So what's next? So the next thing I want to talk to you about is an update that we got on the No Surprises Act. So it's called the Advanced Eob Rule, and luckily the decision was delayed to require what they call an Advanced EOB. So the No Surprises Act. This is a transparency rule, and that was passed earlier this year. I actually put it in a podcast earlier, and it's designed to give patients, advance notice that they have an out-of-network, possibly provider on an emergent basis in the hospital when they have, an emergent situation happens. Well, there's actually part of this No Surprises Act that says that the provider has a requirement to provide the patient with an advanced explanation of benefits, and which makes no sense because the page 6 of this incident basically said that the notification, this was issued on August 20th, said that the network status of the provider or facility, the contracted rate for the item, this is what the patient has to know, the good faith estimate received from the provider, a good faith estimate of the amount of the plan or coverage is responsible for paying, and the amount of any cost sharing for the individual, and then disclaimers indicating whether coverage is subject to any medical management techniques. Well, the problem with this is that patients are coming into the hospital typically in an emergent situation. And the patients aren't saying, wait, can I, see what's going on first before they say, yes, please go run me in for a heart cath. Well, the No Surprises Act is due to take effect January 2022. And the HHS secretary received a lot of feedback from the public, MGMA, and different societies about the challenges of developing a technical infrastructure necessary for providers and facilities to transmit to plans and issuers good faith estimates. Also, how many times has your patient said, I found you in my book as a preferred provider, and you say, no, we haven't been a provider for them forever. So the payers also do not update their information. And luckily, what was delayed on this rule that was again set to take effect January 2022 is that the applicability of this provision until there can be standards that are established for data transfer between providers and facilities and plans and issuers, and they need enough time for plans, issuers, and providers to have some kind of a shared, interoperability infrastructure necessary to support transfers. You don't have any idea what's happening as far as coverages per se when a patient is coming into the hospital in an emergent situation. So this is such a problem, and luckily MGMA really was on top of this. And so we appreciate the intent to increase transparency on how things work, but medical groups typically do not know what services they'll bill for until they see the patient, unless it's a discrete procedure or diagnostic test. And so to ask them to guess is not only burdensome, but will likely result in an inaccurate accounting of what the patient actually would owe. And then an unintended consequence of this requirement would scare patients out of seeking treatment due to expensive and incorrect estimates. Also, the rule presents operational challenges. So we've talked about problems in other areas such as prior authorization. there's a lack of electronic transaction standards for transmitting information from provider to payer. So this further is exacerbated by the short time frame which group practices must turn this information around. So luckily, January 1st, there is a deferred enforcement, and this will give the provider community time, hopefully, along with the payer community, to say we need a standardized process to provide meaningful cost information to patients and physicians. And January 1st is not a feasible deadline because right now the technology isn't working in the physician's favor. And all it does is help payers basically say, great, we're not paying you your out-of-network amount, and the patient doesn't have to pay you, and so the doctor's kind of screwed there. So, and that's actually my personal opinion on that. I hate this act. I think it's important as far as ambulance and certain provisions as far as, hospitals and stuff like that, that overcharge. But when it comes to private practice, I think that it's really making a leap and a stretch. When a patient, they're assuming that you can actually talk to a patient about their money and their account and their financial obligations when they are admitted to the hospital as an inpatient. It just makes no sense whatsoever. So I'm not really understanding what they're doing there. Okay, now we have to talk about Anthem. And Anthem is a Blue Cross Blue Shield provider out of Ohio. And they put out an alert, which also came to me as I am the external consultant for American Academy of Family Physicians. And I also saw that Betsy Nicoletti posted it as well. So obviously we both have insight with AAFP. But Anthem is going to review and potentially deny claims for E&M services based on risk adjustment scores. So I've seen this in the past where a payer may downcode an E&M service if it only had one diagnosis attached to it. And because the payer didn't feel that, a high level, level 5 or level 4 should only just have one diagnosis. They didn't review the notes. They based it solely on the diagnosis code on the claim. And this plan with Anthem, it's slightly different. So it appears that Anthem is going to use risk adjustment to select physician claims to review. So those scores, risk adjustment scores, are calculated on a panel of patients based on all of the diagnosis codes submitted for those patients in a calendar year, not based on the diagnoses on a single claim. So they're going to basically, in a nutshell, decide if a patient is sick enough to be seen for that encounter retroactively. So you need to really do your due diligence on this one because this came out on a June 1st update. So really go to the anthem.com. It's providernews.anthem.com, and you can read about it yourself. But they're one of the biggest payers out there on a Blue Cross level, but they just are constantly trying to do things on the back end. And they say that claims will be selected from providers who are identified as coding at the higher E&M level as compared to their peers with similar risk adjustment numbers. And it says prior to payment, Anthem will review the selected E&M claims to determine in accordance with correct coding requirements and reimbursement policies as applicable, whether the E&M code level submitted is higher than the E&M code supported on the claim. If the E&M code level is submitted higher than the E&M code level supported on the claim, Anthem reserves the right to, as permitted under law, deny the claim and request resubmission of the claim with the appropriate level, pen the claim and request documentation to support the E&M level bill, or adjust reimbursement to reflect the lower E&M level supported. Okay, so that's fine. But the problem is, for me, is the fact that every level 4 or 5 is going to be subject to this. This is going to impact every level 4 or 5. Providers who have certain coding patterns based on their specialty, cardiology, pulmonology, I don't want to put family practice in there because they're pretty much all over the place. But there are certain, oncology, high risk specialties that are looking at multiple diagnoses and multiple situations with patients, although they may be chronic, stable conditions today, and now you're going to have a payer making the physician's judgment decision. Now, one thing I thought was interesting is when this first came out, it said that it was going to be retro, and then I just read to you that it said it was going to be prior to payment. So it'll be interesting to see how they're going to do this, but they said that this is going to be started here in the next couple of months. So be aware of that for Anthem. it really bothers me because I think that we just got an update on the 2021 information for, E&M saying that our physicians are the ones who make the judgments on the medical decision. But now it's saying, well, sort of. Now it's basically the payer gets to say it, but not so fast. And I'm not sure if I'm liking that at all. So this is where it gets very interesting when it comes to certain things like that. Okay, now another thing I wanted to talk to you about, and actually let's just go over some E&M situations, and this will be my coding questions today, because I think we're still dealing with some confusion, and it seems like it's never going to end. But we want to understand what we can count as, I know, data points, and also is it really relevant to the medical decision making? So there's a couple of questions that have come in, and a couple of them also were questions that the AAPC received, and I'm going to disagree with two of them, and I have alerted them that two of them were incorrect because they apparently did not listen to the AMA May 25th errata webinar that was clear on what you can include in your documentation efforts and what you can't as far as your medical decision making. So let's just kind of go over some of them, and we'll see if you have this as far as your understanding, and just making sure that you really understand what your physician gets to count. Okay. So here's one that came in. It says a patient comes in with a new complaint of menopausal symptoms. The physician orders lab work and discusses the risk of starting hormone replacement therapy, and also informs the patient they will prescribe medication based on the patient's lab results. So the question was, does this count as prescription drug management for that date of service, even though they will be waiting on lab results before they prescribe the medication? So if the provider documents that they will be starting the medication and waiting for the labs to return to decide the correct dosage, then yes, I would consider that to be prescription drug management, because they did counsel the patient on what the next step is. They're just waiting for a confirmation, and that's going to be something that you want to have well documented. Another one says, we use a transcriptionist, so the provider dictates and signs the note the next day after reviewing it for accuracy. Can we still bill based on time since the work was done the same day, even though the note is signed the next day? Yes, you can bill based on the provider's time on the date of service that they had the face-to-face with the patient. So the next day that the physician is reviewing and signing off on the chart, you cannot include that time. And so hopefully that makes sense. So here's one of the ones that I disagree with. If a provider orders a screening mammogram during a sick appointment encounter, what we call problem-oriented visit, can that be counted in the data? The answer is no. You cannot count it in the data if it is not directly related to the problems, and I'm air quoting, addressed during that encounter. So otherwise, look at how many level 5s we get from the physician, because they could hit in the medical decision making under data, they could hit moderate or high just by ordering mammograms and screening colons and all this screening stuff, and that is not included. They put on the AAPC website that it was included, and I have alerted them that I disagree with that, because that is incorrect. So hopefully they will change that. The May 25th AMA errata webinar was very clear that unless it's directly related to the problems addressed, that it is not included in that encounter. Our coding question is brought to you today by Medisoft Cloud. Medisoft is a cloud-based medical billing system that is fast and highly scalable platform that transforms the way healthcare providers manage revenue cycle management. Visit Medisoft247.com today. So I'm going to end with my personal tidbit this week. So as I mentioned, I moved my home and my office is closer to where I now live, and that's inland, about an hour from the beach in California, Southern California. And again, talk about a culture shock. It's 20 degrees hotter here. But you know what? It's a good thing. So just for those of you, the reason I brought it up is for those of you that hate change, and I'm raising my hand. I don't like change. I like things just the way they are. Change isn't always bad. Good change is good. And so just really try to be open to things that are good for you, even though it may not be what you're thinking is a good idea. So I've lived by the ocean for over 30 years, and so this is a different thing for me. Also, I wanted to shout out to all of my new Coding Corner membership clients. It is awesome how many of you are now joining our membership community to get your coding, billing, and questions answered. And I really want to just welcome to the fold Midwestern University in Arizona and Waco Cardiology, Memorial Health System in Chicago, Coastal Cardiology, and EE Health in Illinois, Veritas Medical Billing in Texas, Spectrum Ortho in Ohio, Vital Skin Dermatology in Illinois, and right here in California, CV Consultants, Cardiology Consultants, and obviously we've got a couple more. But we just want to make sure that, I just want to say I'm really happy that you're part of our membership. And for those of you that still want to join for questions, answers, and billing questions, and coding questions, and compliance questions, and also help with any appeals, you can email us. It's unlimited for a fee per year. Please go to terryfletcher.net. You can pick either our regular membership or our executive membership, which comes with webinars and an Ask Me Anything session once every quarter. And we're happy to have you. So anyway, that's it from me this week. Everyone, make it a great day and a great next week. And I'll talk to you next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.